continuing to join for the next few minutes, but thought I would get on and say hello and start doing some of our, the business side of our presentation today. So my name is Maria. I use she, her pronouns. I am on the waiver policy and compliance team at the Disability Services Division. And I'm really excited to welcome you all to the overnight supports and services office hours. We have a really robust team of DHS staff who are going to be available for questions that you have coming up. So you're going to hear a lot from me today verbally. I do have a wonderful co-presenter in Andrew, who is on our support planning team. But we also have a really robust team of staff in the background who will be answering questions. So really grateful for their time and their talent and I'm hearing there's a lag in my speaking, my mouth and my audio. So I hope that resolves and it's not a universal experience, but welcome. I know it's been a while since we've done in office hours, so hopefully we can jump back in. I remember our time in 2021 really fondly. So let's go to the next slide and review our agenda for the day. So today we're going to do a general overview of the overnight support services available. We are going to have a specific conversation on how to do support planning for overnight supports. Then we're going to review the night supervision service. After that, we'll get into the frequently asked questions that we have been hearing from you all over the last, I would say, more than a year. We've been having some ongoing conversations since streamlining, really. And then we're going to have that open question and answer time. To facilitate that, let's go to the next slide and do some housekeeping. So make sure that you host yourself throughout this time together. Take care of your needs, whatever you have to do, just step up and go and do it. We are not going to be taking a break, so build in your own breaks, stand and stretch and all of that. Use the question and answer feature to ask your questions throughout. So don't wait until the end to just dump questions in. Like I said, we have a really robust team of DSD staff who are waiting for your questions. So if you could reference either the slide name that's up on the right side or the slide number down in the right corner when you ask your question to help us reference that, where the question is coming from or the content that maybe we spoke to something, that would be really helpful. Otherwise, just general questions, just put in there as general questions, but do it throughout. We are going to leave you all on mute today throughout the presentation, so you don't need to worry about accidentally unmuting yourself, and then cameras will be off. So you'll get to see me, and then you'll get to see Andrew, and that will be your visuals aside from the PowerPoint, which hopefully is taking up most of your screen. And then our slides are going to be posted. I want to apologize that I didn't get them out and finalized in time to be sent with the reminder yesterday. So they will be posted on the train link in the archive. Let's talk really quick about some common agreements that we can have as a group. And we need to assume good intent and be accountable for impact. So we are here in a space of learning. We want to hear from people. We want to hear their experiences. And that intent, it does matter. And we are going to assume that all of the input received and the questions are really well intended. And that being said, that the impact matters too. So if something, if something maybe isn't appropriate or we're not saying it the correct way, we're going to lean into that and just have a teachable moment. Excuse me. It's not good that I'm already cracking at the beginning of the conversation together. If we don't, understanding that we're all going to do better when we all do better. And so if we don't call each other in when our good intent leads to a bad impact, we're not going to grow. We're going to keep perpetuating harm. And so that's why I even want to call myself out on that already. My intent was to get an accessible PDF out to all of you prior to this so people could have the time to go through it. And I did not do that. And I know that does have an adverse impact on people. And I ask that you accept my apology and understand that that might make it more difficult to follow along, or that you might end up having questions down the road after you're able to process the content a little more. And I welcome you to send those questions in, and we're always open to have those conversations. So with that said, let's jump into overnight supports. Next slide, please. So this is our nice image for the day. It's Minneapolis, which is not our capital, but I just loved the bridge and the city and feeling, you know, that connection outside of my office, my little house. So next slide. So we have a couple of ways to support people overnight. We have supports where staff are not physically present in a person's home, and we have supports where the staff are physically present. So when we think about staff not being in a person's home, or not having staff really supporting the person and using services instead, we can think about things like 24-hour emergency assistance, which is going to include the on-call counseling and on-call problem solving or immediate response to provide a person the access to the supports, specifically around medical or personal emergencies. So while this doesn't replace 911, it is sort of a helpful step before a 911 call might need to be made. Maybe somebody has something, they just need someone to talk them through. You know, they're having a panic attack and they need someone to talk them through their steps to come down from that. And so that's something that emergency assistance could be used for. I know we use it for many other things, so that's just one example. So assistive technology as a waiver service is available only on the DD waiver. And assistive technology is something that can replace or supplement a person's staffing and make sure that the person can control and access their home. So assistive technology as a concept is available on other waivers through specialized equipment and supplies, which you'll see on the list below. Then we have personal emergency response systems. And this is going to cover both electronic devices, so like a pendant or a bracelet, which has the panic alert, and the installation and monitoring of that device. So it covers both parts of that service. And then finally, our fourth example of support that could be used overnight without staff physically present is the specialized equipment and supplies. So this service is going to provide devices, and that does include assistive technology, but it's also going to include controls, appliances or supplies that are specified in the person's support plan. And then just remembering that these things can replace a person's staffing support needs and ensure that they can control and access their home independently. These are typically things that you can do in addition to, so you can do them either as a standalone thing, or you can kind of have multiple within this list. So you could do 24-hour emergency assistance and have assistive technology. Like both those things can be true. You could also have assistive technology, and let's go to the next slide, slide 7, something from this list where you have staff physically in the person's home. So we do have some options available where there are staff in the home, and that's going to be our caregiver living expenses. This is a service that is going to pay for the room and board of a live-in caregiver. And then as part of the service, the caregiver and the person are going to develop a support plan together, a roommate agreement, sometimes it's called, where they'll talk about what are the cares that the caregiver is responsible for. And that can include some of the overnight supports. Then we have consumer-directed community supports, or CDCS, under the category of personal assistance. This service option will give the person, so CDCF self-direction allows them to design their services, creating a support plan that will meet their assessed needs. And there's not a limit. So CDCS policy doesn't have a limit on the time of day the support workers may work, but it does need to meet the personal assistance category. And we're going to talk a little bit about that later in our time together today. And then we have night supervision, and this one has seen some recent policy changes, which we've been working on together, right, as a state. We've been hearing from you all. We've done some surveying of families, and so this is a service that's going to provide a sleep or awake staffing for a person who has an assessed area of need overnight for one of the following. It's going to be positive support programming, skill development support, assistance with activities of daily living, or assistance with instrumental activities of daily living. And then we have personal care assistance. So this can also provide support, PCA, and potentially extended PCA. And this is a service that would provide awake staffing for a person overnight who requires covered personal care services. So again, we'll talk about that in a little bit too. Let's go to the next slide, and I'm going to be handing it off to Andrew.
Thank you, Maria. Again, as Maria said, my name is Andrew Johnson. If you don't know me, I am the Support Planning and Informed Choice Team Lead. Today, I'm going to be just walking through some of the support planning and informed choice policy considerations. Selecting a service starts with the person's informed choice, and to make an informed choice, the person must receive the tools, information, and opportunities they need to understand their options. They must receive this information in an accessible format and manner that meets their needs. And the informed decision-making process must occur at least annually and whenever a person's needs or preferences change. Next slide, please. So each service must address a person's assessed need, and the lead agency must document that need in the support plan for each specific service. So when thinking of a service, such as at night supervision, you got to go back to what were the person's assessed needs, and what is the support specific to those assessed needs, and you will be documenting what that service is doing in the support plan to support that need. And each service may address at least one assessed need, must address at least one assessed need, but it may address more than one assessed need. So when developing the person's support plan, the lead agency must base the selected service support instructions, service frequency, and other aspects of service delivery on what is important to and for the person. So it's not just what they need, but also what's important to the person. How do they want that service delivered? When do they want it delivered? And in what manner do they want it delivered? So those are all things that are documented in the support plan. Next slide, please. The section of the support plan in which the lead agency documents this information depends on the person's specific need and how that need will be addressed. You know, each person's support plan should be unique, and you know, where you document things is really based on each person. So the lead agency can document the person's need in any of the following sections of the support plan. You can document it in the support instructions, my plan to address safety needs, goals, and my action items. Those are some suggestions. And again, so there might be a need that doesn't necessarily have a goal associated with it. And so you might be documenting how a service is addressing a need within my action items, or it may be only in the support instructions. It does not have to be in all of these areas, but it must be documented. So as we transition to the revised MnChoices application, there is additional guidance regarding the documentation of assessed needs in the new support plan. Please see the training in the Help Center within the revised MnChoices application for more information. Next slide, please. And as a reminder, the person does not need to fail at using one service before trying another option. Services should address the person's need in a way that promotes independent living. They should be provided in the most integrated manner, minimizing disruption of the person's daily routines, rituals, and relationships. They should be consistent with the person's choice and preferences. And for some people, this might mean assistive technology, and for others, it might mean awake night supervision. DHS provides a variety of opportunity or of services and supports to meet people's wide-ranging needs. So again, a person does not need to fail. And what that means is when thinking of a person's assessed needs, what are the supports that are available to address those needs? And what is the service that they choose? And how does that fit with their daily routines? How does it fit with the important to the person? All right. And that's what I have. Thank you. Now we're going to transition back, I believe, to Maria.
Yeah, thank you, Andrew. That was really helpful to hear about that support plan informed choice. And just as a reminder to put those questions in the chat as we go on, support planning, and Andrew will be one of our wonderful people responding to those questions. So thank you so much. I just really appreciate the time and knowledge that we have on this call today. So let's talk a little bit about night supervision, as we want to do a jump in with this service. I know this was one where we're having a lot of questions. So night supervision eligibility, someone could receive this service if they are living in their own home, and own home does mean either they're by themselves, they live with a roommate, or they live with their family. And then they need to be assessed to need overnight assistance and supervision in at least one of the following areas. So implementation of the person's positive support programming or transition plans. So that's going to be a formal tool or resource. So we should probably be seeing positive supports correlated at some point on the person service agreement. The reinforcement of skill development supports, assistance with activities of daily living, and assistance with instrumental activities of daily living. Let's go, thank you, to not covered. So not covered includes things like night supervision cannot be used to prevent something that hasn't occurred. What this could look like is maybe the person has a history of leaving the home or eloping during the daytime, but this has never happened at night. So we're not going to staff to prevent something that hasn't happened. That's not really fair to the person. It's a little restrictive. And again, we want to meet people's needs in the least restrictive manner. We were not going to use night supervision when it's based on an assumption the person might need a service without having an assessed need for it. So the person, I don't know, maybe the assumption is they're not assessed for like toileting supports, or they're not assessed for like they can get a glass of water independently, but someone on the team thinks that we need to put the support in place in case they wake up and they need help with those activities. They wouldn't know what to do. Well, if they know what to do during the daytime, they're probably going to know what to do during the nighttime. And if they're not assessed to need a support, then we're not gonna authorize something just to put it in place. We also will not be using night supervision. We cannot use it when the person does not have an assessed need for overnight supports. So like that are covered in the eligibility that we talked about before. So the reinforcing of a positive support plan or transition plan, reinforcing skill development, ADLs or IADLs. And then night supervision cannot be used to support a person who is going to sleep through the night, or they're going to wake up overnight, but they don't need that assistance and supervision. So people have a right to wake up in their own home, at different times, and we can't assume a harm is going to happen during that period, especially if there's no history or there's no assessed need there. And then we cannot use night supervision asleep time when the caregiver lives in the home. So a parent or a living caregiver, maybe, different roles where they are living in the home with the person, we can't pay them to be asleep. It'd be paying them to sleep in their own home. Next slide, please. So now we're going to talk about staffing when there are multiple people in a home. And this has come up a little bit frequently. I know there's a lot of drivers that get us to a place where there might be two people with disabilities living in the same home. And we don't need to unpack all those reasons. Let's just go from the understanding that we have two or more people living in an own home setting, meeting the own home requirements, and that both of them are going to require that night supervision. So how are we going to authorize it? So today, night supervision is a one-to-one staffing support service, and the service can only be provided on a one-to-one basis. But it may be possible for a single staff to meet the overnight needs of multiple people. The lead agency would need to assure that authorization and service delivery do not overlap. So it could look like there's two people, 10 hours of night supervision needed. One person maybe needs 5 hours. Second person's going to need 2 to, well, I did it as a 3-person example here and I put 2 on my notes, so I'm sorry. So an example where there are 3 people, say there's a 10-hour need for night supervision. One person might end up with 5, one person might need 2, and then the third person might need 3. If that all works out, that there are not 2 people awake at the same time, then a single staff could provide that time. So the staff is sharing, the staff is shared, excuse me. So the staff person, same staff person, but the total time is not shared. So the time is designated for each individual person. So at no point is there overlapping support occurring. Next slide. So we did have some legislative changes in our last session. We have not implemented these yet. So we have changed statute to reflect shared staffing. Next step is to get federal authority. So we cannot implement until we have federal authority. So how do we do that? We are currently working on drafting waiver plan amendments right now, which is going to include all the relevant legislative changes. Amendments will be published for a 30-day public comment period, and I hope you all engage and give us some feedback on what's going to work and what's not working. And then after the public comment period, we'll submit the amendments to the Centers for Medicare, Medicaid, CMS. Once CMS has them, we're going to work back and forth answering any questions, providing technical assistance, and then when they're approved, we do need to do the implementation process. So any system changes, any policy changes, all of that needs to occur before we will implement shared staffing. So next, thank you. So when we talk about in the future, we'll have this as a shared staff, right? It'll have a 2-to-1 ratio or a one staff to 2. There we go, 1-to-2 ratio. It's important that we have support planning reflective of this change. So a person is going to have a right to choose where they live, whether or not they have roommates or if they're by themselves. And when a person does decide to live with roommates, each roommate who's receiving services must have separate support plans that are specific to them and their needs. Those requirements are going to stay the same, right? We support plan for the individual. When we start developing a support plan, we cannot assume that because there's roommates, there's automatically going to be shared staffing, right? Shared staffing shouldn't be the default or the primary service delivery method. The service delivery should be individual based on what the person needs. And if the person chooses to share staff or chooses to share providers, that is fine, but they are not required to choose a specific provider, especially in their own home. They're absolutely not required to choose a specific provider. And they certainly don't need the same provider as their roommates. So the person and their roommates, they're going to need to have that support planning and those considerations. Each person's plan is going to need to describe how the person made an informed choice to receive shared staffing, how shared services meet the person's needs and preferences, the person's specific support needs met by individual staffing, the person's specific support needs met by shared staffing, when individual staffing is provided, and when shared staffing is provided. And as a reminder, there will need to be releases of information signed in order to communicate and coordinate with the roommates, support staff or their case manager, whoever is helping with the support planning for them. Next slide, please. All right, really quickly on rates, and this is one of our insider folks we have on with us, is a rates person, so thank you for being here today. So here are the two primary questions we get. Will there be different rates for asleep versus awake staffing, and will there be different rates for shared staffing? So regarding the first question, we need to have a legislative change for rate changes. That's all managed in our state statute. We did not get that in 2023, and so our next budgeting year is 2025. Will there be different rates for shared staffing? Yes, just like other shared services, the rate for night supervision shared will be different than the one-to-one rate. Let's go, yes. So we're gonna jump into frequently asked questions, and I do see people putting questions into the Q&A. Just keep doing that. Thank you so much. Very helpful for us to be able to answer some questions. Next slide, please. All right, difficult conversations. So when we were developing this slide deck, we were talking a lot about how do we, like what's going to be the most important, what's going to be hard. So we're like, let's just jump in with the frequently asked questions and really dive in to see what people want to hear. So we have gotten a lot of feedback on it is really hard when working with parents or others. There are times where they're unwilling to try alternative, maybe less expensive alternatives, maybe less restrictive alternatives, but even things like a sleep study or doing something more technical, like looking at assistive technology. And instead they would like night supervision approved for all their children's overnight support needs. As a reminder, all waiver services must be authorized by the lead agency and included in the person's support plan before services are delivered, be for the direct benefit of the person, with the exception of those services that provide relief or training for the caregiver, be the most cost-effective option to meet the person's need, ensure the person's health, safety, and well-being, help the person avoid institutionalization, help the person function with greater independence in the community, meet the person's assessed area of needs, be the person's choice to meet their needs, support the person's desire, needs, and preferences, meet all program and service guidelines in the federally approved waiver plan or AC protocol, be related to a person's disability, be authorized within allowable rates, be within the allowable budget of the county or tribal nation, and if it was AC and EW, be within the case mix cap. So that being said, this might lead to having those difficult conversations of saying, well, no, the person's not eligible to receive the service, right? Like just because an option or a service is available, right? We have these robust service menus with over 30 services on each waiver. That doesn't mean you are eligible for every single service that exists on the waiver program. So that's kind of that first step of, does the person even meet the eligibility requirement for night supervision? How do we get to those places? I think the other considerations are going to include things like, is this long-term or short-term? Yeah, what are we doing to help support the person? I've been talking with a lot of people recently about like children who are at that 12 to 16-ish age range, and it's difficult for them to manage all of the person's support needs as they're going through a bunch of changes. And so things ebb and flow, and it's up to us to have those difficult conversations and really get into that nuance of where we can and cannot do things. So just because night supervision is an option, it doesn't mean everybody is eligible for it. It doesn't mean not to do it either. Like we discussed earlier, if the person needs that level of support and they have the assessed needs, they meet the eligibility criteria, and that's their choice, then yeah, like let's get it in place and help support that family and that system. Next slide, please. Okay, parental responsibility is another big one that we get a lot of questions on. What is parental responsibility? How do we define parental responsibility? I think historically we've kind of had a hard time with this, and there's, those intersections between children and family services and behavioral health. And so when we talk about it from the DSD perspective, obviously the waiver is always the payer of last resort. And we talk about parental responsibility, and that's an activity or task that a parent of a minor would ordinarily perform or be responsible to perform. So that could be things like, kids don't sleep through the night their first couple of years, right? Like they might, even as young toddlers, they might have up and down periods at night. And so that's a child development piece. Kids get sick sometimes. Like I've had to sit up late with my kids when they've gotten the stomach flu. And so that's sort of like, that's a one-off normal kid thing. However, if you have a child who is, getting up multiple times a night, they are, doing the stimming, or maybe it looks like trying to leave the house, or maybe it looks like other things like that related to the disability. Well, it's not normal for a 7-year-old to get up 6 times a night, right? Or it's not normal for a 12-year-old to try to, well, I won't say that because there are some 12-year-olds who do probably try to leave the house overnight. But let's say, it's not typical to see that every night or constant, ongoing, that need for intervention. So we don't want people, to be in a situation where they are not getting the supports they need in their home. We can't just assume everything is parental responsibility. And that's going to mean also being comfortable with being uncomfortable. So I think about that too. It's like you're going to have to probably navigate family values, right? The state and the counties and tribal nations should not be providing family values or dictating how a family system looks. But the family might have things that they value as important. So it might be really important for a family to have, different, I can't think of a good example with night supervision right now. But I just think about like sleep time. It might be really important for a family to not have staff in their house overnight, but they really need some supports. So it's like, how do we navigate those two things? How do we talk about, okay, assistive tech or emergency response, 24-hour emergency response that we can call in, and the family, we might run into a family who like, yeah, we're really tired. Okay, well, you don't want people in your house overnight. What can we do during the daytime to give you some support? Is there more respite time that we can add? Right. So it might be like that's a roundabout way. We're going to meet an overnight support need by putting in day supports, because in order for them to meet their family values, maybe they want that safety of just being able to lock up the house and not have anybody they don't know really well in their home. Okay, so how do we meet that need if they're doing all the disability supports overnight? There might also be, conversations around child development, and nobody expects anybody to be a child development expert per se, but there are expectations, and the assessment does outline age milestones for ADL dependencies. And we do need to have some understanding of what is typical and what is atypical in child development. And I know we rely on our mid-choices assessment to help us with that. So that's a good resource to go. And then just other clarifying conversations, right? So there might just be other ways of looking at working with kids and defining parental responsibility that's unique to that family system. And so that's going to be potentially uncomfortable conversations because it's not a typical practice. There are some universal things that we do, but then we also need to scale it to family-centered practices and looking at that system instead of just at the individual, right? It's person and environment kind of work. Next slide, please. All right, technology. So we get a lot of questions about how can assistive technology and or remote support be used for overnight staffing. So as a reminder, remote support is the provision of a covered service by staff or caregiver at a remote location. And then they're engaged with the person in a live two-way communication. So remote support is a delivery method, right? We are doing IHS with training remotely. The service is happening like this. So say we just turn on another camera and start talking, but I still need to meet all the service requirements for IHS. So that's going to be kind of the same thing with remote support. I think we have over 20 options at this point. Our assistive tech person is here today as well. So those remote questions, assistive tech questions, monitoring questions, we do have somebody here who can help us answer those for you as well. Again, thank you so much for your time. And then assistive technology is going to be things that help people of all ages with all disabilities to increase, maintain, or improve independence. And this is going to be in different locations, right? Home, school, work, communities. We have some really great assistive tech resources I would direct you to. The Minnesota Guide to Assistive Technology is a webpage, really robust, that we've worked on with community partners. We have our community-based services manual, assistive tech page, and the specialized equipment and supplies page. So I would direct you there for those resources. But when we're having those conversations with our families, remembering that assistive tech or any technology, it can be used to reduce staffing, or it can be used to augment staffing. You might put something in place and the person might still need that staff person there too to help them. So it's really a spectrum of what these supports and services can do for a person. So just make sure that you are considering and having those conversation of the person could choose a combination of assistive tech and remote support that supplements the overnight in-person staffing. They might choose to rely solely on assistive tech or remote support for their overnight needs. The overnight supports should match the assessed needs, the overnight support needs, and prioritize their preferences and choices. So again, it's what the person, how do they drive their support plan? How do they understand and make that informed choice? And again, just as a reminder, assistive technology is not always intended to replace the in-person care when a person needs or prefers that in-person care. However, the person can use it either to supplement or to replace when assistive technology meets their needs and the person's made that informed choice for assistive technology. Can you go to the next slide, please? So here we go, personal care assistance overnight. And we do have a wonderful member of home care team on to answer questions. So thank you so much for being here. Really appreciate the time and the expertise. We have the question often of how does personal care assistance, PCA, work for overnight supports? So PCA can pay for time when the person is asleep and the staff is actively performing a covered service, or the person is awake and staff are actively performing a covered service. So let's go to the next slide and we'll talk a little bit more about covered services. So obviously, there are some limitations then. When we talk about what PCA can do, there are some clear limitations. The PCA, it cannot pay for time when the staff is sleeping, and it can only pay for covered services. So there are 4 categories of PCA services eligible for payment from MA, and that includes activities of daily living, instrumental activities of daily living, observation and redirection of behaviors, health-related procedures and tasks. So a PCA worker can assist in these 4 categories if the following criteria are met. And that's going to include that the PCA care plan describes the person's needed assistance, the training of the PCA worker is specific to the person's needs and occurs in the first 14 days of PCA service for the person. There's documentation in the agency's file on the individualized training, and the PCA worker documents services rendered on the timesheet or in another agency format. Next slide, please. So when should a lead agency authorize night supervision instead of PCA for overnight assistance with the activities of daily living? We have been having a lot of conversations recently around state plan services and waiver services particularly with the intersection of the staffing shortages, and how do we meet all those needs. So as a reminder that anytime PCA meets the person's needs, and that is what should be authorized, as PCA meeting the person's primary ADL support needs. The scope of night supervision is broader than the scope of PCA. So night supervision is assistance and supervision of the person overnight. And that does include assisting with ADLs. And if the person would have the need for both assistance and supervision, then it could authorize both. But it really, if we're talking about the hands-on care, and I understand that with the limitations on PCA overnight and billing limitations, that can create some sticky situations. And that might be then when we talk about how do we augment with some of the tech, how do we augment with some of the remote options, all of that is where we get to have some creativity and meeting overnight support needs. So next slide. So consumer-directed community support, CDCS, personal assistance. And we do have a wonderful self-directed staff on the call today who is going to be helping answer questions. So thank you so much for that time. How does a person on CDCS receive overnight support? So the lead agency is going to evaluate, lost my place in my notes. That's fun. They're going to evaluate the person's need for overnight supports that fit within the personal assistance category. So it is limited to personal assistance. The staff, again, must be actively providing a covered service. So CDCS can pay for time when the person is asleep and staff are actively performing a covered service, or the person is awake and staff actively perform a covered service. Next slide, please. We are also going to talk about those same limitations that exist in CDCS. So we cannot pay staff for time when they are asleep in CDCS. And people who need overnight support must fit the costs within the CDCS budget. So there is not, I know there are CDCS exceptions in very rare instances. There is not a budget exception related to overnight support needs. So it will cut into the cost that a family has, what they can spend their money on. And there are those limitations about staff needing to be performing an active area of the personal assistance category. Next slide, please. Minor children. Okay, what supports exist for children younger than 18? So a lot of these are going to be the same as other, as adults, right? Services exist for most ages. There are some age restrictions. However, children younger than 18 on any of the waivers can receive overnight support by staff through the following waiver and state plan services. That 24-hour emergency assistance, CDCS personal assistance, night supervision, and PCA with that ADL support only, since there are IADL limitations. Parents of minors cannot be paid to provide night supervision or 24-hour emergency assistance to their children. Under CDCS, parents of minors can be paid to provide services for their children. And to understand more about that, please refer to how does a person on CDCS receive overnight support? And that is in our Q&A, our resource document online. I'm going to drop that for my colleagues to send your way. And then as a reminder that children younger than age 18 can also access assistive technology through either the AT service or the specialized equipment and supplies. Next slide, please. All right, supporting the family and person during service transitions. Okay, let's go to the next one. So we do have a lot of questions coming in about families, parents, both of minors and adult children. And so we want to take a look at what supports exist. And I think it's something that we as a state, really do need to lean into how do we help support children? How do we get through transition years and then moving into young adulthood, right? Like that is something that is a special interest, I think. I don't know if that's the right words to use, so I apologize if it's not the right words. But when a person does transition from their family home into their own home, the family might be a significant change for them. The child is an adult. They have rights and autonomy to take over control of their life. And I know many of our young adults do find themselves under guardianship, but even within guardianship, they have rights and they do have decision making. For a parent or caregiver, this can really create a shift in the mindset, right? From parenting a child to having that relationship with an adult child. And regardless of disability or ability, that is a hard transition time where you're starting to change your role and how you interact with that person you've raised up to this point. It's a natural and gradual separation, and it can help, for children with disabilities, there can be some supports by the waivers to help ensure that everyone's needs are met during that transition. So thinking about what's available, case managers, there are a lot of tools that we're working on around this, and services that we should be implementing before, throughout, and probably a little bit after major life changes. That's going to help provide people and their families a roadmap to navigate these new and unfamiliar territory. So charting the life course tools, these are great guides and tools, different activities. They can really help shape what the person sees for themselves, what their goals are, what's important to them, and start that individuation process of becoming their own person separate from their parents. We obviously have person-centered planning, and this is going to help a person find their voice and explain their dreams for the future. That is under the family training service. So you would authorize, as a case manager, authorize family training for person-centered planning facilitation, and the code is S5110. There is a person-centered planning frequently asked question page. And once you get the PDF, you should be able to, use the hyperlinks to get to some of these resources I'm saying. And then family counseling. This is, again, one that's sort of underutilized. So I think we see a lot of, there's a gap right around how do we support parents or siblings who are having a hard time with that separation, family boundaries, relationships, all of that can be explored in family counseling and can really help create opportunities for the families to redefine what their family structure is, what they need as a family, what their goals are, right? It can help sort of reestablish some of that stuff. Living with a child with disability often means very different than living with kids who don't have the same intense support needs. And it's really hard to step back and let that go, right? We hear that a lot from parents. I know other people have experienced it too. It's hard to let any child go out and make mistakes. But when you've sat in a hospital with your young child as they have gone through kidney failure, or when your child was born with Down syndrome, and maybe you heard from a medical professional that the best you can expect out of life for them is to be living in a 4-person group home without a job, going to a day program, or you'll have to take care of this person their whole life and your whole life, right? It's a very different mentality, and a lot of times it is a fight. It feels like a fight for the family. And so we are then asking families to step back, right? We sometimes use some uncouth words. We say coded things like it's a difficult parent. But when we think about that journey of not just how did the person with the disability get to this point in their life, but how did that also impact the parents, right? So I think there's some empathy building for us, but even more than that, there's that service of family counseling that can help the family unit reestablish boundaries. It can help support the parents in that separation. And I just think it's a really great opportunity, and it's something that needs to happen before a transition occurs, right? Like, or before a crisis occurs, or before a major life event. So we can't just be like, oh yeah, by the way, they're moving next week and we think you should start therapy, right? Like that's not how therapy works. We want to give people tools before a change happens as often as we can. Let's go to the next page. There are also things like self-advocacy available for people to talk about things. There are housing stabilization services to help people maintain housing, so that can be a help and a relief for the family. But let's also talk about the right to risk and the dignity to risk. This is a really hard conversation. So discussions with the person about risks are going to include many perspectives from formal supports and informal supports. Each person who is involved in that person's life is going to have a different understanding of the benefits of self-determination. So we think about circles of support, right? There might be people from all the different rings, but probably from that innermost ring and then the second ring of very close friends. There will be a lot of people who care. They just care a lot, right? Like that's, I think what we have to remember is that everybody just cares a lot. We all care a lot. And the people we support want to have control over their lives, and the people who love them care a lot. And so when we talk about dignity and risk, it's gonna be a hard conversation because again, families have been doing it, right? They're like the warrior for their kids, or maybe it's a sibling who's like, no, I got to be there for my brother or my sister. So being able to hear all of those perspectives is important, and then making sure as we navigate that, that lifelong learning and independence comes from opportunities when people get to make their own choices, right? So we know that as people get to make more choices, yes, they might make a mistake, but who doesn't make mistakes, right? We all make mistakes. And the research does show that people with disabilities who have greater opportunities for self-determination, they're going to live more independently, have increased skill acquisition, they're going to be healthier, they're going to be better adjusted and better and able to identify and resist abuse. And so it's again, like, how do we honestly, in a lot of ways, get out of the way so that people can just direct their lives and be okay with making some risky choices. So, well, let's go to the next page. There are resources for right to risk. So again, we really do want to support you all in these conversations and in these support planning, because it's one thing to be like, people who have self-determination do all this stuff, and it's another thing to be like, okay, now go out without resources. No, please use resources, empower yourselves, learn for yourselves what exists out in the community or what resources we have developed. So, living in a community, it does come with expected risks, regardless of the level of supports that a person has. So we do need to have resources available to help, understand how to mitigate those risks or understand how to live as safely as you can in a community. I just think about it for myself all the time, right? As a woman, if I go out on a walk or a run or a bike ride and I want to listen to music, I only put one earbud in because I need to be aware of my community, right? So there are just risks when you live in the world. And we can talk about how sad that is or how difficult that truth is, but it's the reality. So we need to help make sure people are safe when they make those risks, that they have the ability to make decisions. Yeah, and to be able to make that informed choice, and maybe it does include risk, and that's okay. Again, it's how do we help people, not ourselves, but also how do we help the people supporting the person manage their feelings around the person taking risk. Go to the next slide, please. I think we are at open questions and answers. I am going to mute for about a minute here and let you guys process, put more questions in, and then touch base with the team. I think I mentioned all the different areas who are here except for assessment. We do have someone from assessment here. Thank you so much. They are also sharing their expertise because we do get some questions about assessment. Kyle, could you please go back one slide? And then we do have a few regional resource specialists on the call as well, doing some of our support for me with the slides, but also answering questions. So I'm going to mute for a minute and then we will circle back into the open question and answer. We do have this space available for us until noon, so we have a good chunk of time. I don't know if we're going to need all of it, but go ahead. Okay, hopefully that was like all the time you needed to saturate an hour of information. I am kidding. Continue to incorporate the information into what we know. I hope you're not sick of me yet because I'm back. I'm still here. I'm going to answer the Q&As. Let's go to the next slide just so that we have that. I just really like that image. It felt very calming when I was developing the slide deck. So yeah. Here we go. So what, if any, overnight supports are there for the elderly waiver where a service worker can actually be in the home overnight with a client? So today we are focusing on overnight supports for people with disability waivers. Please contact the Aging and Adult Services Division, and their email is dhs.aasd.state.mn.us to learn more about overnight support options for people on the elderly waiver. Okay, I have been told by 3 lead agencies the previous MnChoices assessment did not address assessing a person for a need for a sleep overnight staffing. Is this true? If this is true, will the need for a sleep overnight staffing be addressed in the new revision? So the MnChoices assessment does address the need for 24-hour plan of care. This includes the need for a sleep or awake supervision. The assessor considers the person's ability to remain safe while alone, and these items are also included in the MnChoices revision. When developing a support plan with the person, the case manager reviews the considerations shared by the assessor when discussing all of the available support options. The overnight support a person needs is based on the person's assessed needs, when they need the support, what they need support with, and the person's choice. There's a lot of words, but that's a great answer. I like that one a lot. I like all of them. I love all the questions and answer. Guys, this is my favorite part, remember? Okay. For the first bullet point, to prevent something that hasn't occurred as a preventative service, though we are aware that our human services judges are not proficient in all things DSD, we lost an appeal and a reconsideration for just this. The individual reported that she could need assistance throughout the night. The judge ruled with the individual and we lost this twice. Is there any collaboration between DSD to train judges on our services? Yeah, absolutely. DSD trains and provides technical assistance to appeal judges regularly. We will add training on overnight supports with appeal judges to our work plan. So, yeah. So we have talked about examples of children accessing night supervision. We had a request for examples. There's some very young children whose parents request night supervision, but refuse to work with a positive support professional for FBA development of a PSP and training caregivers and staff. If there is a specific need for behavioral intervention overnight, the service is correlated to that positive support plan. So we can't just be like, well, they have behavioral needs, let's put in night supervision, right? The waiver plan, the way it reads is that it does need to have that correlated plan in place. We don't want people trying to intervene. Yeah, we want them to follow the positive support plan, which is why the service is written that way. Okay, so very exciting to hear the issue of shared staffing or shared night supervision being sent to waiver amendment. I'm wondering if it has been considered to include ratios greater than 1 to 2 for people choosing to live together and are determined eligible. Thank you for that question. We will add the ratio suggestion to our list of policy consideration. We also encourage you to review the amendments when they post and submit the public comment with the recommendation as well when that's available. Again, that would be a statute change as well for those ratios because they are also set in statute. I think it does get to be a little complex and we need to talk about what do people really choose to live with each other? Do they really have overlapping support needs? All of those things we've talked about already, especially as we add more people to a home. We don't want to be replicating a residential service or assuming people need shared staffing or need the same supports, right? So it's kind of a both and. Is there anything, okay, so I think this came after like kind of a conversation from the person about authorizing services and services being inappropriately provided at this point. So the question is there anything that DSD can do now about this being inappropriately provided? So anytime services are being inappropriately provided, it is the lead agency's responsibility to intervene. So the lead agency has the responsibility to ensure that services are authorized consistent with the state and federal requirements. So if there are questions about a service or other waiver plan requirements, please use that DSD contact to get a specific technical assistance action going. On page 21, can you link the CVSM or where we're getting the information? Yes. So that is under the I think that link got sent in, but it's the CVSM, it's the waiver overview page where that information is about how services must meet support needs. Regarding night supervision and sharing staff, can you clarify if we can currently approve one staff to provide night supervision to more than one client if there is no overlap, even when we are currently awaiting federal approval of staffing? So let's go back to, oh, Kyle, I don't know what slide number it is, but it's at the top. It's gonna be slide 18. Nope, slide 16. Can you zoom us all the way back? Everyone close your eyes for the ride. Okay, this is the one where I was like, oh, I think I mucked that up. So I'm not surprised we got a question. So when we say it's possible to have a single staff support 2 people, today, as the system exists, they cannot have any overlapping support needs. So it is about person A doesn't need the whole night of staffing and person B doesn't need the whole night of staffing, and their support needs don't happen to overlap. So it is a one-to-one service. It cannot, if I'm working with person A and person B is needing the same thing or is coming in, there's not a way to support both of them at the same time. So it only works today to share a staff in a one-to-one situation. So we've seen cases where it's like one person is up from midnight to 1 and then another person gets up like at 3 a.m. and that works, and then the sleep time can be divided between the 2 people and billed, individually for the 2 people. If you have 2 people who have needs constant throughout the overnight time, you're not going to be able to perform that, and you'll need 2 staff in those situations. Hopefully that clarifies. Can we please go to slide 33 again? We have a comment. Thank you for this comment about asking if the state could publish some success stories, some content about that, videos, short narratives, that could help other individuals and their teams see what it would look like, and that could help the difficult conversations. Many providers create their own, but the families remain skeptical the providers just fluffing a narrative to get more people on services. So the comment was also that Ohio did this very effectively. So we will certainly reach out to them, and truly any providers, if you do have a success story, I know it's not traditional or lead agencies, but please feel free to send those in for us too. And you can just say it's like overnight service success story, assistive tech success story. We got one from a provider recently, like within the last 2 years, where they shared their success with how they changed their medication administration. And it was really great to see that. And then we were able to use that concrete example in different scenarios. I don't know that I have permission to share the provider name, but they did a great job with the that conversation, tracking what they did, the success, the changes. So that was really helpful to us as a state. This might shock you guys, but we only hear what we hear from you a lot of times. So families don't often call the pot. We do talk to some families, but we serve over 60,000 people on the waivers at this point. So if I hear from 5 families, that's awesome. And it's just not enough, right? We need to hear from more families and more people. And so lead agencies and providers are a conduit for how we can make those connections as well. So thank you for that comment. Okay, related to elopement and seizures, for example, if a person has demonstrated that they have eloped and have significant seizing during the day, but has not yet demonstrated either at night, if requested, are we not to be approving of night supervision, or is this still an agency decision and discretion? This is a popular request and a really hard decision. Further discussion on this area would be helpful. That is a really hard decision, right? Like, how are you going to say no to somebody who's like, I am very worried about my child having a seizure and then being disoriented and leaving the house? Because it's happening, right? It's happening during the day. if it's not happening at night, we can't authorize the support for something that's not happening. That's a really hard thing to say. I would say make sure there's seizure monitoring happening overnight. I know seizures are so individualized. I am not a medical professional, and I am not going to say no. It's always no. I'm going to say, you need to really monitor that activity and be working with the medical professional on the seizure protocol. And at any point that can change. So a no for now is not a no forever, and making sure you have that conversation as well. And that, again, that's a really hard conversation because seizures are very scary, very complex. Same thing with eloping. It's scary. We talk about it as eloping, and it's just scary. So no, if the person is not having that happening at night, we can't authorize the support for nothing, if that makes sense, during that time. Okay, if a child or an adult has behavioral needs and the caregiver is requesting staffing at night because the person wakes everyone up at night, goes into drawers, cabinets, concerns for safety, is loud, or tantrums at night, needs assistance to help return to sleep, but the caregiver refuses to work with positive support professional or another MA service, they just want staff at night. If behaviors is the only eligibility criteria for night supervision, should we still authorize the service? So again, the way the service is written today, there is a correlation with the need for a support. It is implementation of the person's positive support programming. So that is the eligibility criteria, which I think we're talking about it as behaviors, but I want to be clear that the actual language is that it's implementation of a person's positive support programming and transition plans. So they need to have a positive support program, or they need to have a transition plan. Behaviors are not actually an eligibility criteria independent of those things, if that makes sense. We talked about, so this one, I believe you're talking about family counseling. Are these services available for kids under 18? Thinking specifically about families going through divorce and needing to reestablish routine care and supports for child under 18 between the two parent homes. So if I am wrong in my assumption of what service you're talking about, please clarify. Yes, family counseling does not have age restrictions on it. It just needs to meet the eligibility criteria. Okay, we've got more questions and we've got time, so feel free to keep asking questions in here. I just lost my space, so I found it again. Thank you for giving me my pause. Can we clarify the answer to the previous question? Does the assessment directly assess the needs for night supervision, or is it implied assess needs? So we did kind of talk about this earlier, but let's say it a different way. The assessment does indicate that a type of support is needed. However, final determination of how those assessed needs are addressed in the person support plan does lie with the person, their informed choice. And when a person has an assessed need, the case manager must discuss the assessed need with the person and present all the available options. An assessment may not explicitly indicate that the person has needs overnight. The case manager must consider the need, the time of day the person requires it, what supports they're going to need, and the whole person. Are there other options? Are there less restrictive options? Are there more integrated options that would be less intrusive or restrictive? Ultimately, if there is a need for overnight support, the person's choice from the available options must be honored. So it's a little bit more nuanced, I think, than is there or isn't there, right? Like, yeah, there might be support needs that are happening overnight, and the person might be choosing, like we talked about earlier, the person might be choosing not to have someone in their home. They don't want someone in their home overnight. Having had people in my home overnight providing supports to someone I care for, it can be uncomfortable to have people in your home all the time. So that's part of this conversation too. I think we're all coming at it from the perspective of people wanting this or needing this or what we think is best, and being able to take a step back and just be like, here is your options. What's missing from your life, or where do you find need for this support? All right, we have a PCA question. What if PCA is not accessible to the person? Do we deny other services like IHS and night supervision because they can be authorized for PCA? And then we ask for clarification on that. And not accessible meaning none of our providers are offering PCA at this point because of the low reimbursement rate. So there is no PCA staff available. Providers are offering individualized home support and night supervision because it pays better. And if there are no workers or providers available, do we authorize waiver services to meet their need or leave them with no services? Yeah, this is a very real thing that we see happening right now, right? Thank you for that question. That's a hard question, but it's real. If the person is found eligible for PCA and PCA is the most appropriate service, then as part of support planning, the person should be offered access to that service. If there are providers and workers available, they are entitled to their state plan service. If the person has been found eligible for a waiver, meaning that state plan cannot meet all their needs, as part of support planning, you would have to develop that person-centered plan to meet their needs, including health and safety needs. So again, this idea that a person doesn't need to fail at one option, because that determination of need is being made in the assessment. So we're opening a waiver, we're saying it exceeds the state plan, but it's really, again, the person's choice. If a sleep paid staff is available as a service throughout formal waiver services, traditional waivers, how can it not be used through CDCS? Can you expand on that, please? So under the personal assistance category, sleeping, you have to be doing an active service delivery. So sleeping is not a covered service within CDCS personal assistance. It's just not an available option. It's one of the limitations on CDCS. Okay, are these services available for kids under 18? I think I answered that one. About if services are available, yes, they are for, it was that family counseling, I thought, and I said, please add more if we were wrong about that service. Yeah. Okay, I am wondering how night supervision is the most cost-effective service that will help increase independence for someone under 18 when they're reported issues related to mental health service. Parents are demanding the service, yet refusing positive support services or mental health therapy and possibly medications. Instead of finding ways to improve things, they only want to consider night supervision. So I think we've talked about this a bit already. Behaviors are not a reason to author it, right? You need a positive support plan. It's right there on the eligibility page. That's what the waiver plan says. So you have to have that correlating plan. And night supervision does not meet the FBA. You cannot do a functional behavioral assessment under night supervision. That's not a requirement for staffing. So hopefully that helps with those conversations. I think another piece is, again, we talked about earlier, let's dig into that. What is the family really needing and why? What's the stigma around other supports, and how can we help address that and help move the family beyond that? Again, we've talked about at the top, like we are intersecting when we're talking about kids with disabilities, we are also intersecting children and family services. We might potentially be working with behavioral health. That's a lot of systems too, right? To to have to manage as a case manager or as a lead agency. So I think it's digging into some of those conversations and where are the barriers and why. I hope that it makes sense to you when I say that you have to have that positive support plan or a transition plan. That helps clarify and how we can approach families. If behaviors are the only, if, seemingly behaviors are what's being presented as the support need overnight. I also just wanted to name that I feel like there was a lot of frustration in that question. So just making sure that's maybe a point where we need to check our frustrations and then spend more time, not just the person who asked that question, but the state spending more time on figuring out how to better resource for that. Just like we talked about with that conversation around dignity of risk and right to risk. We need to make sure there are resources available to help navigate those conversations. So the waiver program overview doesn't help us determine if we should authorize night supervision related to a person's behaviors if the service eligibility criteria speaks to a person is eligible to receive night supervision if they live in their own home, are assessed to need overnight assistance in one of the following areas. Implementation of the person's positive support programming and transition plan. If there's no positive support plan, what directs the night staff? You can't authorize it. So I hope that I think we've had this question in 3 different ways pretty much, but it goes back to you have to have it. You can't authorize it. Otherwise they don't meet the eligibility criteria. Just like for any service, you must meet eligibility criteria to get the service. So that sounds really cold and it sounds really easy to say studying at DHS. So I just want to be clear. I'm trying to empower you all to understand that line. I'm not trying to be cold or not trying to be like, it's easy, because it's not. You're sitting in front of real people and again, they care a lot. They care a lot about their kids and you care a lot. And part of your role is also saying, here's the box we have to color in. So I'm just trying to give you that box really clearly. Okay, if there are no workers or providers available, I think we're back on PCA. Do we authorize waiver services to meet their needs or leave them with no services? So if the person has been found eligible for waiver, meaning that state plan services cannot meet their needs, as part of the person's support planning, you do have to develop that person-centered plan to meet their needs, including their health and safety needs. I think we kind of touched on this before. I think you were trying to ask for a very clear yes or no, and there's not a clear yes or no on this. It's based on what the person needs. We understand that the provider pool is really stretched to the limit right now. There's a lot of factors for that, including the staffing shortage, including reimbursement rates. So you're going to have to sort of lean into that with each person and use that idea of, like, if they're found eligible for a waiver, like, how do you incorporate the waiver supports? Where do state plan no longer meet their needs? And that sort of delegated authority to the lead agencies and case managers. Is there a specific reason that overnight supports provided by the waiver has become so complex, complicated in own home services, but if a person chose to live in a provider controlled setting, it seems so much less complicated or scrutinized? We don't bundle services in own homes. This is like one of my favorite talking points right now, because CMS has been having fun sort of dictating what is bundled and what is not bundled. And my favorite example, so we've experienced in a few places. My favorite example right now is environmental modifications for houses and cars are bundled when they're together. So we had to separate them in the waiver plan. So I don't know why that one just makes me laugh, but I'm like, okay, I guess we got to unbundle it. I would say historically we had been using, especially on the DD waiver, we had been misusing service that was bundled and should have only been used in residential. So as a state, we had to correct that. BI, CAC, and CADI have always had the same access for overnight support. So this is sort of pulling the BI, CAC, and CADI technical assistance and direction over to people who are on DD. So our residential services are bundled, which is reflected in the rate, but it also means they have the whole array of supports and services within that one daily unit. So if that makes sense, I understand it seems complicated. Part of it is the bundling and unbundling. Part of it's providing services one-to-one, meeting the different spectrum of support needs in the home, right? Like we have 8 or 9 services that we named for overnight. But really we need to have those individually based services. And like I said, for folks on BI, CAC, and CADI, who didn't have the same access to SLS that the DD waiver population did, this has been how they've service planned for these supports overnight. I think they're just from like another sort of extraneous position, they've been historically underutilized, overnight supports have. So we're kind of getting into what does it mean to have overnight supports in your own home. And it is a shift and it is a stretch for our state. So that's probably another reason why it's feeling really complicated, because we're all learning together. Okay, we understand that the person should be offered access to PCA services and are entitled to that service. The barrier we face is that some PCA providers will not provide PCA. They are stating they can only provide night supervision. We have individuals who are assessed ADL needs overnight, needing assistance with ADL onlys, and PCA providers are stating they can't provide PCA services, only night supervision. So I think we've answered this a few times, this idea that people have a right to their state plan services. We need to address those individual concerns. Once a person has been found eligible for waiver, it does indicate that state plan services cannot meet their needs, but we still need to meet those person-centered planning support needs. And person has to meet service eligibility criteria. So that's another thing we'll keep going back to. You have to be eligible for the service that you're being authorized for. I am trying to get my document to catch up. Okay, I'm going to jump down to one question and jump back up because I'm kind of reading through things. So my understanding is that assistive technology can still be approved for overnight support as long as it meets an assessed need. It does not have to be linked to approval for night supervision. So for the case where someone has seizures and elopement concerns during the day and they do not get the night supervision approved, could they still use assistive technology to help with the assessed need of elopement and seizures regardless of the time of day? Yes, that is correct. So that assistive technology is a standalone service. It is funded under assistive technology on the DD waiver and specialized equipment and supplies on the BI, CAC, and CADI. So we would use that service as a great alternate option. So this one is the person identifies they want to live with alternative overnight supervision, remote, I think it's remote technology, and assessment shows they can live in their 4-person CRS, but Guardian states if this moves forward, they will pull them from their current living environment. What resources are available for both? I think we might need that to be a specific send-in for technical assistance. That sounds like a very specific case, and I have a lot more questions than answers for you on that one. Anytime we're using technology, it has to be the person's preferred choice and it has to meet their needs. You throw Guardian in there and it does get more complicated. And so that's where we need to be able to have those conversations with the Guardian about, oh, look, we're right on it. Supported decision-making, informed choice and risk, and all of that. But I think there's probably more to that question that I'm missing. So if you could submit that to the DSD, and Kyle, if you want to move forward to the DSD contact form. Okay. I believe we have reached the end of our questions so far. I'm gonna wait 1 minute as I do, and we'll see what else comes in. Again, we have the time, so I don't want to end if people still have questions, so. I do see that another question came in about PCA, so we are working on clarifying. The night supervision service is more than the PCA service, so if they only need that ADL hands-on care, we can't, we have to meet the eligibility criteria. I think another piece to remember is that if a provider is enrolled to provide a service, they should be meeting that service scope. And so, again, that's a hard conversation because they can choose their business model. But it's not clear to me that they would be enrolled to provide PCA and then say they don't provide PCA. So that's kind of also an enrollment record question for them too. Okay, I did just want to touch back again on the eligibility criteria for night supervision. I know people have been asking a lot about that and specifically looking at behaviors, right? When somebody has behaviors only, and they don't want to do the positive support. So I think I had answered in the idea that you need to have positive support or a transition plan in place to authorize night supervision. That is only in relationship to if the person is accessing it, due only to behaviors. So remember, there are those other eligibility criteria that they could meet and other covered services. So it is more than just assistance with the positive support plan or a transition plan. It's that assistance with ADLs, IADLs, and then reinforcement of skills. So I did just want to remind that too, because I think we focused in on that, and now we zeroed in on PCA. So I just wanted to make sure I took that step back and just reminded that it's a larger scope for that. So I think that we are kind of at a winding down point. We will incorporate where these questions, maybe we'll take the questions and do that further analysis between the resource document that we have and the CBSM page and make sure that we're covering the frequently asked questions. As always, you can reach out to the Disability Services Division through our contact form. If it is about overnight supports, please put that as the subject. I do want to just say a really big thank you. Like I said, we have a really robust team here from DHS, the Disability Services Division, who have taken a big chunk of their time in planning for reviewing materials and then participating in this. So we really, really do want to support you all in the work and make sure we are meeting those needs of the people we're supporting. It's a big program. It's got a lot of nuance, and there are a lot of individual needs that we need to meet. So just thank you so much for spending this time with us. Thank you all. Always really just love this time together where we get to really dig into some policy questions. And with that, I'm going to say goodbye and is it Wednesday? Have a great Wednesday, everybody.